discuss beyond the three topics. Thank you.
So thank you, Professor Chow. I think Professor Rimassa has already detailed a lot of the latest development with all those clinical trial data. I think nowadays we have many treatment options for our HCC patients. Of course, the question is, what's the best sequence? I think nowadays, most of us will treat them with those immune checkpoint inhibitors combinations, and then followed by TKI. This is probably the reasonable approach for many patients. But my feeling is maybe for some patients, we may have some better second-line treatment for them, like maybe some other immunotherapy like T-cell engager or CAR T cells, or even some may still benefit from some combination of like ipi/nivo or some other TKI plus immunotherapy. We're still waiting for the Iron Brave 251 to see whether the continuation of PD-1 is working. So I think in the next few years, it will be very important for us to know more about the sequence for our patients when we have more data from those new novel therapies or some sequential studies. Another area that I think I would like to mention is we're still quite lacking behind in terms of personalized medicine. We don't have too many biomarker-driven therapy. I know it's difficult for HCC as compared to lung cancer or gastric cancer, but still I think we should develop some more stratified or personalized treatment for our patient in the next 5 to 10 years. So these are the 2 points I would like to mention. I leave you to our experts in China or Lorenza to comment further. 谢谢你们. Thank you.
Thank you. We have a question that is very confused to me, because the clinical trial of Himalaya and the Checkmate 9DW, that these are similar for PDR1 and CTLA-4. So what about the difference or the choice when we how to choose the immunotherapy for liver cancer?
I leave to Lorenza answer first, and I can supplement later. Difficult question. Sorry for Our Lady.
No, thank you, Steven. It's a really difficult question because, of course, we don't have a comparison, so it's always difficult. I think since we don't have any direct comparisons between the different these two combinations, and we have a very good results in terms of efficacy, what we have to consider is the patient population included in the trial and the baseline characteristics of the patients, for instance, the liver function, the comorbidities, concomitant medications. In the Himalaya trial, we have seen that we can have a long-term survival, and we have some exploratory analysis, of course exploratory, but showing that there is a benefit from STRIDE also in patients with cardiovascular comorbidities and also in patients with metabolic comorbidities. We have seen the long-term survival regardless of the etiology of the disease, meaning HPV, HCV, alcohol, or metabolic syndrome. And also we have seen that the long-term benefit can be observed regardless of baseline liver function. Of course, liver function that should be well preserved because patients were enrolled in a phase 3 trial. But if we look at the ALB grade, we observed a benefit regardless of the ALB grade. That was not seen, for instance, with the addition of bevacizumab. Regarding the Checkmate 9DW, we have less exploratory analysis because the trial is more recent, but we have that shape of the curves. At the beginning, there are more death actually in the nivo-ipi arm compared to the lenvatinib arm. This is probably related to toxicity associated with the 4 doses of ipilimumab, while the anti-CTLA-4, while in the Himalaya we have a single priming dose of tremelimumab. But for the Checkmate 9DW, we need more data regarding that first part of the survival curves. Actually, also for for the checkmate 90W, so the combination of nivo-ipi. We have now very recently presented exploratory analysis showing that also patients with, let's say, negative baseline prognostic factors do benefit from the treatment. This is important. So what I think is that is quite difficult to say, oh, this is perfect for this patient, this is perfect for another patient, because as Stephen was saying, we don't have a precision medicine for patients with HCC, we don't have biomarkers. But it's important that we have more and more options for our patients. And then I think we have to decide in clinical practice. We are physicians, also we also are investigators, but we are physicians, so we see patients in the clinic. And so we have to try to identify which is the best treatment for our patients, considering all the different factors, the data from clinical trials and the clinical factors of that specific patients.
Thank you. Thank you. So let's invite Professor Xu to discuss, share your opinions.
Thank you, Professor Cao, and thank you, Professor Rimassa. And I very agree with Professor Rimassa's opinion. With the release of Humanitas study, checkmate 90W and Embrace 150 study, the central question we now face is no longer if to use immunotherapy, but how to choose between the T+A combination and the promising dual immunotherapy. Currently, there are no perfect predict biomarkers. Our decision might rely on the assessment of patients and disease characteristics. I think the choice might depend on 3 key factors. Point 1 is liver function. For child POA patient, and I think both are options. For patient with compromised liver function, dual immunotherapies, lack of VEGF rate make it might more safer. And point 2 is bleeding risk. This is critical, in my opinion. Any high-risk varices or recent bleeding contraindicates bevacizumab. In this case, dual immunotherapy is the mandatory pathway. Point 3 is treatment goal. And if the goal is rapid tumor reduction for commotion therapy, we might choose T+A. If the goal is to maximize the chance for long-term durable survival, the dual immunotherapy might offer the most impressive long-term tail on the survival curve. And this is my opinion. And thank you.
Thank you for your opinion. So Professor Xu, you mentioned about the choice of the first-line treatment. We should focus on liver function and I think esophagus and gastric varices is very important, and the tumor status, etc. So there are many choices. So it's very complicated, but I think it's a very good thing. So we have so more choice. So what about the opinion of Professor Chen? If we combined the local treatment and systemic treatment for the local advanced HCC.
Yeah, thank you, Professor Chow. Maybe I can add, I have some supplement on the choice of first line before I go to the combination. My feeling is, do we really have to bother about the choice of first line? My feeling is they all improve the survival compared to the TKI. I think the decision finally relies on the as mentioned by you, I think the most important is the toxicity profile, subject to the patient individual status. Just like pancreas, you can give Folfirinox or Gem and paclitaxel. It doesn't matter. as long as patient could tolerate. The survival, my feeling is even you run randomized studies, probably all the first-line regimen will be similar. So I think finally the toxicity profile will be the important. Going back to your your question on local regional therapy plus the immunotherapy, I think this is a very interesting approach. We know that from all studies, the TACE, IMRO1, and also the LEAP-012, we know that they could improve the progression-free survival quite significantly. But the problem is, at least from the LEAP-012, all patient bases, we know they do not improve the overall survival. But then we learn from our China colleagues that you approve the drugs, the regulatory, based on the China subgroup that improve the overall survival. So my feeling is this is not the regimen for everyone, but maybe for some subgroup, maybe happy Chinese, or some patient that we would like to improve the symptom rapidly, or hopefully we downstage the patients, then we may offer this treatment. But probably we should not offer to everyone because the OS is not improved. And we know that sometimes it may harm the patient by the toxicity, worsening the toxicity. So I think in the future, or at least from those published phase 3 studies, we should conduct more analysis to see which subpopulation will be benefited more from the combinations. I know sometimes the pharmaceutical, they don't like to do that. They seem to tell us that this is not for everyone. But I think it's quite clear that only a proportion of them, they benefit more. While for all, maybe they just need the sequential TACE followed by the systemic when there's a TACE failure. So this is my thought. I agree with your question. What types, maybe beyond up to 6 or 12, or maybe some certain population, they benefit more. We need more data.
Yeah, if I may add, I fully agree with Professor Chan, and I think that yes, for patients with a liver-limited disease and not high tumor burden in the liver, I think that we will continue using TACE with no need to add systemic therapy, because adding systemic therapy, of course, we have a benefit in progression-free survival, no benefit in LEAP-012 in overall survival. We don't know yet for Emerald-1 and TACE, but we will see. But so we have a benefit in progression-free survival, but we have an increase in toxicity. We can have a deterioration in liver function. We have the patients have the burden of going to the hospital to receive treatment. There is an increased cost in terms of financial costs. So without a benefit in overall survival, I don't think this will be the option for all the patients with a liver-limited disease. Since now we know that we can, let's say, convert or downstage patients with high tumor burden in the liver, or even advanced meaning macrovascular invasion, not, of course, extrahepatic spread, but we can convert them to surgery and liver resection or even liver transplant. There will be soon a publication, not with the TACE, but with systemic therapy followed by liver transplant. So I think we needed to think that for some patients, using the most active regimen will be the best option. So probably for some patients, TACE plus systemic, and then if there will be a good response, then we will consider surgery or transplant. And okay, but for the other patients with the, let's say, intermediate or advanced for a minimal vascular invasion, I think TACE will still be, at least for some time, will be the standard of care, and not all the patients will receive the combination. And actually, there are patients with a very, very advanced disease in the liver that will be treated maybe with the systemic therapy without TACE. We have now some preliminary data. We will see if we will, then in the future we will use a systemic therapy. So I think, as Professor Chow, you were saying, we have more and more options. So this is very good for our patients. We need to learn how to use the different options in different groups of patients.
Thank you very